Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it's my great pleasure to welcome Dr. Sorensen for this interview. Thank you so much for joining us today.
You're welcome.
Today, we will feature your publication titled Bleeding in Patients with Infarct-Related Cardiogenic Shock, a DanGer shock substudy. So, Dr. Sorensen, I would like to begin by asking you, what gap do you think in our understanding of cardiogenic shock and MCS prompted this substudy of DanGer shock trial?
Well, in the DanGer shock trial, we included patients with STEMI complicated by cardiogenic shock, and it showed a benefit on all-cause mortality in those patients treated in the Impella arm. However, we saw a threefold increased risk of bleeding. So we know that bleeding complications are often associated with increased mortality, why it's crucial to understand when and how the bleedings occur and what the story of that is.
Excellent. Thank you for your answer. That makes sense. And then on that note, if you could briefly explain the results of your analysis for the audience, and how do you think these findings should influence patient selection for microaxial-flow-pump support in STEMI cardiogenic shock?
Okay, so I think we have three main findings from our study. First of all, we analyzed what was the timing of the bleeding events in these patients. And surprisingly, we saw that only 2.7% of the bleeding occurred during the time in the cath lab, which we thought was a bigger proportion than a lower proportion than expected. Secondly, we found that approximately a little under 50% of the bleeding episodes occurred while on mechanical support, whereas the last 50% of the bleedings occurred after removal of the mechanical support device. And that was an eye-opener for us, emphasizing that these critically ill patients are dysregulated in their coagulation system, and that we need to pay attention of their care throughout the whole time period they are treated.
Thank you, Dr. Sorensen. And that makes a lot of sense, like especially in the closure, the events that we saw, and which we deal with every day when we are closing these large bore accesses. So thank you for sharing the results.
We found in our study that the type of mechanical support is affecting the risk of bleeding. We found that the more complex the mechanical support is, the higher the risk of the bleeding, with the highest combination associated with the use of both microaxial-flow-pump and VA ECMO at the same time. The third finding of our study was that we found that bleeding complications were associated with of course, the advancement of mechanical support, renal replacement therapy, and more severe infections in the intensive care unit, like ventilator-associated pneumonia, as well as sepsis. So regarding the selection of patients for mechanical support in STEMI with cardiogenic shock, I would say we are still in our center applying with the inclusion criteria of the DanGer shock trial. And if you routinely want to expand that inclusion of patients on mechanical support, it should be backed by evidence. I think that is what history has shown us.
Absolutely. Thank you, Dr. Sorensen, again. And lastly, after these results, what future research do you think is needed to better define the safest use of mechanical support in cardiogenic shock, especially in STEMI patients?
Thank you for the question. I would say acknowledging the difficult clinical setting of doing research in this field, I think it's crucial to find out the evidence behind mechanical support in different populations. It can be both more sick population, older population, younger populations, and of course, if you extend the indication, does it apply for patients with non-STEMI and also those with out-of-hospital cardiac arrest, which were excluded from our study. The other thing I think is necessary to be aware of is we should do some research on how we should do the anticoagulation while on mechanical support, what type of medication should we use and how should we monitor it. Right now, it's very diverse what people are doing, and that might increase the bleeding risk. And at last, I would say in these patients that are all nearly treated with percutaneous coronary intervention, the need of antiplatelet therapy needs to be addressed in some research in these very selected populations. Maybe monotherapy for a short period of time combined with anticoagulation could be enough, and in that way decrease their risk of bleeding. But of course, it's a difficult field to do research in, and I really hope we can keep up the good spirit across the world for doing that.
Absolutely. Those are great points. Thank you, Dr. Sorensen, for sharing those points. And we deal with it all the time, like, the difference in practices of different cardiologists all over the world. Like when we're closing large bore accesses, the patient is usually fully anticoagulated because of the STEMI, and most people would not feel comfortable reversing with protamine at that time. So a lot of discussion points. Thank you again for joining us today, and big congratulations to you and your team for this work.
Thank you. Thank you.